Hello everyone, this is Arushi Sharma, one of the internal medicine residents at St. Vincent Hospital. As we all know, atrial fibrillation is an irregular and often very rapid heart rhythm that can lead to blood clots. It is usually managed with either rate or rhythm control agents. However, ablation is currently indicated for patients with paroxysmal or persistent atrial fibrillation who are intolerant or refractory to drug therapy. It can be done in the form of a cryoballoon ablation or a radiofrequency ablation. As with any procedure, there are complications. And today we talk about one of the most under-recognized complications of these transseptal procedures, which is persistence of an iatrogenic atrial septal defect beyond 6 months. Majority of them spontaneously close by 12 months. However, 26% can persist beyond this time. There was a recent study which was done. It showed patients who have undergone cryoballoon ablation with a 15 French sheath. The incidence was noted to be as high as 17 to 38% at 4 to 6 months, and then 20 to 37% at 12 to 36 months. Today, we present an interesting case of a 57-year-old gentleman with medical history significant for obstructive sleep apnea, atrial fibrillation, and tachycardia-induced cardiomyopathy. He was being evaluated for new onset exertional dyspnea and lightheadedness. On reviewing his previous records, it was noted that 2 years ago, he underwent cryoablation for persistent atrial fibrillation. Thereafter, he was being managed with either rhythm or rate control. On examination, his vitals were stable, his heart rate was 99. His cardiovascular exam showed a 2/6 intensity ejection systolic murmur heard in the left upper sternal area. He subsequently underwent a TTE with agitated saline contrast, which revealed findings consistent with left to right atrial septal defect and right-sided chamber enlargement with ejection fraction of 55%. Thereafter, a transesophageal echocardiogram was done to further characterize. It showed that his defect was 0.6 centimeters in diameter, after which he underwent right and left heart cardiac catheterization, and those revealed normal coronary vessels. Prior to his pulmonary vein ablation 2 years ago, his baseline TE had shown an intact interatrial septum. Due to his given findings, he's now being referred to a higher center for further evaluation and possible closure of this defect. On discussing this a bit further, cryoablation procedure involves larger sheath size, more sheath maneuvers, and inflation of cryoballoon across the septum, all of which favor higher incidence of atrial septal defect in this technique. Due to higher left atrial pressures encountered in this patient population, it minimizes the incidence of right to left shunting and hence the rate of paradoxical emboli. However, importance should be given to consider post-procedural assessment of the interatrial septum after such transseptal procedures with intracardiac Doppler echocardiography during the procedure and or with surface echocardiography and bubble study during follow-up. Thank you for listening to this presentation.